a pleasure to be here with you, as always. And it's a pleasure to be at this meeting geared to cardiac tumors, something that's not given enough attention at most times, at most places, most conferences. In continuing what you suggested, I think you did suggest something along the lines of a registry hopefully sponsored by some of the major surgical societies would go some way, if not all the way, in setting this up. At the least, one could have a registry of cardiac tumors in Ontario, then Canada, and then, of course, if you were able to join the STS registries and have a cardiac tumor registry, it would go much further in giving us some real statistics. Given the fact that there are virtually no autopsies done anywhere in the world today, at least in North America and Europe, very, very few autopsies, we don't get real stats of those patients that you mentioned get left behind, don't get surgery, don't get referred for surgery, and such things. We do need tissue for pathology, as you pointed out, but we also need some clinical information from you. Do give us some clinical information. Make the pathologist's job a little easier. Without that information, we're often fiddling around in the dark. With that, let me also say that I said there no conflict of interest, but I want to add an acknowledgement. I think 5 of my slides are taken from the web. Most of them are acknowledged. 2 at least are tables, and I couldn't fit in the acknowledgement. So I am acknowledging the people, mostly from the Mayo Clinic, whose tables these are. They were on the web, and I have taken them from there. My objective is to give you a brief overview of the spectrum of cardiac tumors. Okay. I will follow that very, very briefly with a gross and microscopic description of some of the tumors. But by and large, I want to run through tumors that you can see. And if I have time at the end, and if RJ doesn't yank my cord, I'd like you to tell me what some of the images are, what tumors they are. You can do it. They're very simple, and you've probably all seen them many times. My final thing is also the last thing that RJ said. So have you appreciated the difference between tumors and non-tumor masses? The word tumor is something that I learned in virtually the first day of my time at med school. Cala, ruber, tumor, dolor, and tumor was any mass, hopefully not inflammatory. So we did go to the third slide. The heart, as you know, has end-differentiated fibers, and you do not get tumors of the heart or cancers of the heart or neoplasms of the heart. However, the heart has many other cells in it than myocytes, and these can give you neoplasms. Most of these are connective tissue or mesodermal cells, so virtually all neoplasms that you get in the heart are those that arise from mesodermal tissues. The malignant ones are all sarcomas, at least the primary ones. Metastatic ones can be anything, of course. The heart was called the royal organ, and this is why the ancients, the Greeks, said the heart does not get tumors. The heart does not get any illness. You just die with your heart. We know that's not really true. What is the role of the pathologist? The obvious role is to give you a diagnosis. Often enough, you have a diagnosis in your mind, from the radiologist on to the cardiologist and cardiac surgeon. You think it's a tumor. You think it's a malignant tumor. However, it's the pathologist who finally tells you, yes, it is a tumor. Even more importantly, tells you, no, there is no tumor. It's just a thrombus or an organized clot or something along that line, and you do not need to do anything more about it, as RJ showed in that case of his, where all of it was clot sitting in the pericardial sac and giving you a tamponade. I said this earlier, and with this, cardiac tumors can be tiny, they can be small, or they can be large. The spectrum of tumors that I am going to show you is confined to adults, and the benign ones from there are myxomas, papillary fibroelastomas, fibromas, very rare, nodal tumors, lipomas. Lipomas used to be common. They're not very common anymore, and I'll tell you why. Of the malignant tumors, they may be primary or metastatic. Primary, as I said, will virtually all be sarcomas. Metastatic can be any tumor from anywhere, although the nearest viscera are the ones that give you the most common metastases. Tumor-like conditions are more often clot. The clot itself may be calcified, may be totally acellular and difficult to decide what it was, though you can say what it is. Other rare conditions can also be seen. And the newer entity that we talk about instead of lipomas are lipomatous hypertrophy, and I hopefully will show you one example of that. This is by no means a complete listing. We did a review of cases at our institution, just as RJ did. Ours covered the period 2006 to 2017. We had 162 primary tumors. 64% of the masses were primary tumors. Of these, 15% or 37 cases were also metastatic tumors. The total was about 256. Pseudotumors or non-tumor masses, non-neoplastic masses, 51 cases, 21%. And of those, thrombus accounted for 14%, thrombus in various stages. As you open the pericardial cavity, the first thing you might find is a pericardial cyst, usually benign. Pericardial malignant tumors are exquisitely rare. One doesn't get many mesotheliomas of the pericardium. Very, very rarely you might. In my career, I've seen one, and that was referred in from an autopsy from another institution. You do get enough pleural, and you can get spread to the pericardium, but not usually primary. I have acknowledged in many of them, courtesy Uncle Google. This is a table taken from the same Mayo Clinic and lists some of the tumors and some of the clinical features, etc., associated with them. Myxomas are perhaps the most common benign neoplasms. I and a couple of my colleagues disagree. We think the papillary fibroelastoma is probably the most common, most unrecognized neoplasm in the heart. Myxomas can occur at any age, can occur from the first decade of life right up to the end. The common clinical presentation, often picked up for when investigated for other reasons. They can be picked up for mechanical reasons, obstruction of a valve, or just a feeling that I've got something in my heart and it plops. 2 to 10% may be associated with the Carney syndrome, where there are many other tumors of many other soft tissues. Most, in our series, close to 87%, occur in the left atrium, the rest in the right atrium. There is no such thing as biatrial tumors. The biatrial tumors are those that arise in the left ventricle, grow through the foraminal into the right side, and then are listed as biatrial tumors. These tumors are supposed to be reportedly pedunculated. There is no peduncle. These are sessile tumors. The lipomas now are exquisitely rare. Let's leave them. Lipomatous hypertrophy is increasingly common, usually a widening of the interatrial septum, though you can find larger masses of these fat cells bulging into the right atrium and causing obstructive symptoms. And, as I'll try to show you, they can occur at other points also. Papillary fibroelastomas generally occur in older individuals, and as you all know, they can cause you the classic embolic events, transient blindness, and such things. All the other tumors are considerably rarer, and I won't go into those. Which is the tiniest tumor in the body that can kill you? The tiniest tumor is the nodal tumor, the AV nodal tumor, less than 1 millimeter in diameter, usually picked up by the pathologist at autopsy when he, just for completion, takes sections of the atrioventricular node and you find a tumor there. This one is also taken from the web. I have seen 2 and reported 2 large nodal tumors that RJ had excised. This is a tiny tumor, no more than about 2 millimeters in diameter, sitting on the root of the tricuspid valve. When you look at it, it looks like a vascular mass. When you do the immunostaining on it, you realize that it isn't a vascular mass. This is almost a mesothelial type of tumor, and this is an atrioventricular nodal tumor. It causes sudden heart block and leads to sudden death. As I said, I think this is by far the most common tumor. If you put this in water, you get the beautiful picture that you see on the right and the top. Funny, it resembles the headgear of some people very well and resembles the sea anemone equally well. This is what a PFE looks like when you do the histology. On top, you can see the endomyocardium, and then you have usually a palm tree-like bowl, and then numerous branches arising from it. They have a specific histologic pattern and are covered. All of these fronds are covered by endothelial cells, and you know you're dealing with a papillary fibroelastoma. Myxoma, by far the commonest of the tumors, excised by a cardiac surgeon, and as RJ said, we've had a large number of them in the last few years. In reviewing our cases, we found that they could be divided into two types. The first, or type 1, is the smooth-surfaced, solid-looking mass, often lobulated, the lobulation being because of the mass prolapsing through the mitral valve and getting relatively constricted at that point. The surface may show superficial patchy ulcerations where thrombus lies, and this can lead to embolic events. This is an example of a small myxoma, no more than 1.5 centimeters in diameter, with a thick, smooth surface. As you can see, it arises from the endocardium, and I'll have to skip that. This next one is the more usual. This one weighed almost 80 grams. The surgeon has taken a tremendous amount of endomyocardium off it from the interatrial septum. The endocardium is the area that we, as a pathologist, section completely to ensure that there is a good margin all around and no chance of a recurrence. You can see the smooth surface, and you can see the hemorrhagic areas. The hemorrhagic areas are largely due to the movement of the mass within the left atrium, and it's kissing the mitral valve. Not a good idea. This is the type 2, much softer, much more gelatinous, much more myxoid. Notice that there is no pedicle. This arises from the endocardium, and its feeders come from there. Notice in this case, too, that there is no pedicle at all. The whitish tissue that you see at the base of the lesion is the parts of the tumor that have slowly fibrosed thanks to the hemorrhage into the tissue and the reaction to that. This is the endocardium covering them. But in the core, there is still the tumor, and it does not extend into the subjacent tissues at all. This is what a myxoma classically looks like. I'm sorry, I'm going one way and I want to go the other way. The clinical manifestations from this series are what you see here. About 15% show embolic events. Most show transient obstruction of the mitral valve. Many are asymptomatic and picked up at investigation. One of the somewhat surprising things that came out of this review, we tried to break it down by ethnic groups. And we were able to recognize from the name alone, not from anything else, that some of these were clearly ethnic minority cases. Very surprisingly, these 7 patients presented to the surgeon or to the cardiologist considerably at a younger age than the mainstream population. A difference of 18 years is a very clinically significant difference. We don't know why these patients present earlier. Last year, when we had a visitor from India in the group, a visiting pathologist, she had mentioned that in their patient population too, the patients presented to the physician at a significantly earlier age, almost the same difference as you see here. I wonder what the difference is, and maybe some of the younger folks will be able to look into it in the future. In our case, 55 of the masses were left atrial, or 88%, and 4 were right atrial. 3 at that initially were undetermined, but these were ultimately shown to be from the left atrium. Only 2 cases were part of a Carney complex. Primary cardiac malignant lesions are virtually all sarcomas, and these are the different types of sarcomas. Most of these are rare. This one, the lymphomas, are even rarer and are much more common in those with HIV infection than those without. Today, many of these tumors are listed simply as intimal sarcomas. I put intimate there because they tend to hug the inside of the vessel or the inside of the heart and give you that tumor. Most of them run along the intima without invading the wall of the vessel or the wall of the chamber. Only about 15% of primary cardiac tumors are malignant, and of these, sarcomas are the most common. As RJ said, there's no way of being very sure about the incidence of this. Most of the initial numbers came from autopsy series, but today we don't perform autopsy. As we know, most tumors show an upward trend in incidence, probably the same for the heart, but we still aren't able to figure that out. For the malignant tumors, there is no gender predilection. Myxomas, as you know, are 4:1 more common in women than in men. Median survival after diagnosis is only about 6 to 12 months. These are some things that Dr. Wynn will talk about, and I don't need to bother about these. While Dr. Wynn and the cardiologist give you a diagnosis of this as a tumor, you can't be absolutely sure till the pathologist signs off, and no one would treat a tumor with the death rays or anything else till you have a signed report from a pathologist. Let me show you a couple of cases. First one is that of a young woman who had no significant past history. She had a two-month history of palpitations associated with occasional episodes of left arm pain and shortness of breath. Transthoracic echocardiography showed a mass, and she was referred for urgent consultation. Dr. Cusimano would recognize the case without my having to say anything more, and this is the mass that you can see. The echo findings were summarized as a large mass, at least 33 millimeters into 34 millimeters, prolapsing into the right ventricle through the tricuspid valve. Mass appears to involve the posterior aspect of the aorta, coronary sinus, and septum, with significant obstruction of the tricuspid valve. She was referred to Dr. Cusimano. Patient arrived, had significant difficulty in breathing, and a bedside echocardiogram to me was reported as, let's take her to the OR immediately. This is the TE in the OR. Large mass, significant obstruction, and extending into the right ventricle. Unfortunately, she could not be operated. She died soon after this. The family consented to palliative care only, and she passed away about a day and a half after coming to our hospital. So we had a young woman, severe right heart failure, large right atrial mass, prolapsing through the tricuspid valve into the right ventricle, sudden deterioration, tamponade, and she died. This is the heart with the right atrium opened. That's a large mass sitting in the right atrium. The mass could be lifted up. You can see the constriction there where it went through the prolapse through the tricuspid valve. We transected, we cut the heart longitudinally, and you can see how extensive the mass is. The mass extended into the interatrial septum, but did not go through the endocardium on the left atrial side. Histologically, the mass is a very cellular, very pleomorphic, lots of necrosis, lots of mitosis. You can see a mitosis at about 3 o'clock in this screen. None of the immunohistochemistry was of much help. Electron microscopy, fortunately, showed lots of lipid vacuoles in many of the cells. Those grayish circles that you see are lipid vacuoles, and this was ultimately a liposarcoma grade 3, and she had tamponaded and died. Another example of a similar mass. This is the mass at echocardiogram, and this patient had a device in the right side of the heart, and this is the mass that was growing along the device. This, as you saw from the clinical, had to be scooped out. This mass histology shows this appearance. The red star is not the Heineken star. It's just to highlight the core where the pacemaker lead went through. This is the immunohistochemistry on that, and the immunohistochemistry shows that these are all vascular cells, that this was a angiosarcoma. Metastatic cardiac lesions can come from, cardiac tumors can come from anywhere, and you're seeing a long list of potential sites here. You can make a diagnosis in this case, and there is metastatic tumor on the epicardial surface everywhere and in the right atrium. Our guest from Melbourne can diagnose the first two hearts there, those black deposits. We don't see them here very often, but in Australia, where melanomas are much more common, you see them far more often. The two lower pictures show metastases from a bronchogenic carcinoma. And here, this is a large number of metastases in the left heart and the right heart from a colonic adenocarcinoma. What about cardiac pseudotumors? They can be any one of these, often difficult to diagnose unless they are totally acellular. Let me show you an example of a young male, 2 to 3 month history of increasing dyspnea, chest pain, discomfort, lack of energy, fatigue. There's a past history of alcohol use, not abuse, and has quit some time ago. Dr. Kuzabana was remember the case from the clinical so far. He was obese and had greater swelling on the right side than the left. A needle biopsy was performed in December of last year, and the clinical concern was a sarcoma. It was reported as consistent with lipoma after doing molecular studies. At the time of surgery, which was done largely for mechanical reasons, there was a 860-gram mass of adipose tissue. That's the mass. And that scale on the right side is 15 centimeters long. You see the deep surface. That crater is where it was excised from the ventricle. And the right side shows you the free surface. This is the histology. Myocardium at the bottom. The black rim is where we painted it with India ink to show the area where you had excised it from the surface of the heart. The myocytes extend into the adipose tissue, into these mature fat cells. So this is not a lipoma. It is just lipomatous hypertrophy. Most of the time, lipomatous hypertrophy occurs in the intraatrial septum. Very rarely, and this is the first time I'm seeing it elsewhere, it can occur at other points. There's a closer look at the same thing. And the free surface does show a smooth capsule-like surface. Okay, what would you think of this mass? Right atrial mass, you can see the dimensions, you can see the endocardium. The white is the endocardium, the yellowish area is the mass, close to the margin on some sides. I thought I had one volunteer, but he told me not to call him out by name, so I won't call anybody out by name. And now you know that this is a organizing thrombus. I'm not showing you the histology on this. Another mass growing around the pacer wire. Remember the mass around the pacer wire that I showed you earlier, which was an angiosarcoma? This, fortunately, is just a thrombus. Men show thrombus growing around these chambers and around these devices much more often than women do. This is a case from long ago. A large mass from a 57-year-old person who had the mass for about 10 years in his left ventricle. About 6 months Prior to the surgery, the mass had started growing, and the surgeon felt that this was definitely a sarcoma, and he took it out. What would you think of it? Or is there anything else you want me to tell you before you tell me what it is? The mass is calcified over most of its surface. Even the endocardial surface that you see here, the deep yellow areas are calcification. Anybody from a sheep rearing area would probably take the hint that this is a mass with something growing inside it. Those grayish areas are something that was growing there. When you look at the histology, a membrane like this, train tracks, positive on PAS, looking deep pink, and with little calcified debris on the right side in the necrotic masses. This has to be from a gentleman from Afghanistan who had sheep that he was rearing and dogs that he had as pets. So this is a hydatid cyst. Unfortunately, or surprisingly, we could not find any evidence of a hydatid in the liver or the lungs. The usual thing is for them to have a hydatid in somewhere in the GI tract, and then the liver, and then in the lungs, very occasionally in the heart. We couldn't find anything like that in this individual. This is metastasis in this case. What do you think this heart shows? Both from the same heart, and you're seeing the right side of the heart. The mottled gray is the liver cut away, the inferior vena cava. Sorry, I'm not able to manipulate the arrow very much. I didn't have a liquid dinner, but I'm still having difficulty manipulating the arrow. Sorry. What do you think of this mass? Perhaps the commonest source of metastases to the heart, especially vascular metastases, are renal cell carcinomas. This is a huge mass that grew into the inferior vena cava and into the right atrium, prolapsed through the right ventricle, through the tricuspid valve into the right ventricle, and the gentleman died of those lesions. There is such a thing as a cardiac mice. This mouse is ashamed to be involved with that. If you don't make the diagnosis soon enough, and if you hunt around, you might find more of them, and if you wait a little longer, you'll see a whole family of mice. Mice are monocytic incidental cardiac excrescences, little masses of mesothelial cells, endothelial cells, and a few other inflammatory cells. Benign, just sitting in the heart, waiting to catch somebody make a mistake. What about this one? What do you think this one is? Left atrium, mass peeping at you. It's not a peeping Tom. It's a myxoma. This patient had mitral valve reconstruction, and 3 years later had this mass growing just over the annuloplasty ring. Any idea what this is? It certainly looks like a type 2 myxoma that we called. On the gross, you cannot absolutely exclude a thrombus, but I would bet pennies to pounds that this is a myxoma. It was a myxoma. Thank you very much for being such a wonderful audience. Thank you all for being here at this tumor conference. I have tried to show you a spectrum of cases and very briefly covered most of the cardiac tumors that you'll see. Also covered most of the non-tumor masses that you'll see in the heart. There always are surprises, just as that hydatid was for us. There continue to be surprises. That's what makes it fun to continue to work, for you to continue to operate, and for us as pathologists to continue to do the pathology with you. Thanks very much.